topic we're going to be going over today is sepsis. By definition, sepsis is bacteria in your blood. Oh my goodness, what are you talking about? Yeah, that is the last place you want a bacteria to be. You don't want bacteria in your blood. It's not supposed to be there. That's why we have mucosal defense, right? To prevent bacteria from going into our bloodstream. But once they get in there, we develop sepsis. But before we go forward, we need to understand the sepsis pathway. Because before the bacteria gets into the blood, we're going to get a little wink, wink from the body telling us, watch out, watch out. So what are we going to start with? We're going to start with a systemic. The entire system is affected. Inflammatory response syndrome, which we're going to talk about. What is the definition of SIRS? Well, you have to meet at least 2 criteria of the following. What? We got to meet 2 of all these criteria to meet SIRS syndrome? Yeah, but before we explain, we need to explain what SIRS really is. That's going to start with the pathophysiology of sepsis. Here, down below, don't laugh, that's my funny little neutrophils, and those are the macrophages. They got guns, yeah, I tell you, they have really big guns, and that is bacteria. So that is a bacteria who has a suicide mission. So we're going to start with a nice little story. So a bacteria was sent to go blow up stuff inside our body. You know, bacteria they love to destroy things. So they wrapped them up in a bomb, and guess which bacteria it was? It was E. coli. Escherichia coli. And it's other friends. Aside from E. coli, it's all the bacteria that cause sepsis. We're going to go over that in a minute, but we're going to just pick E. coli. And around E. coli has all these endotoxins. Now, when bacteria take a sneak peek into the bloodstream, guess what's going to be activated? Neutrophils are going to be activated. Monocytes are going to be activated through interleukins, cytokines, telling them, I smell a problem. There's an intruder. When the invader comes in, they put out their guns and they're about to go shut them down. So the neutrophils and the macrophages, they rush inside the bloodstream. And this is the beginning of the pathophysiology of sepsis. However, these patients are usually going to start up with a fever. All right, so here's the story with fever. I told the story before, I'm going to tell it again. In medicine, right, anytime you hear fever in a location, always remember, for you to have a fever, I'm going to show you my nice little chimney house. Okay, here's the chimney house, and that's the kitchen. So back in the days, they used to have chimneys. You probably still see houses that have chimneys, and there's always smoke. So let's say you're cooking here inside the kitchen and you burn stuff, or there's so much smoke, it has to go through the chimney. Well, as an observer, when you see the chimney and the smoke coming out, you're like, I think something is burning inside the house. You might want to go check it out. Wait, that is the signal the body sends out. The smoke is the fever. Oh, you start to shake. You get feverish, you get warm, you get chills. Well, that's the smoke, that's the fever, that's the body's response telling you there's something going on. But the kitchen is the location, because guess what? It's the bacteria that's causing you to have the fever. So check this out, guys. Fever and a headache. I might have an intracerebral abscess or meningitis. Oh, look at that, sepsis, man. If I have fever and meningitis, fever, headache, rigid neck, guess what? The fever is telling me what's going on. There's a bacterial infection, and it's going on inside the head, so I have a headache. Because it's irritating my meninges. Ooh. What about if I have a fever and I have cough and I'm short of breath and I have productive cough? Well, it's coming from the it's coming from the lungs. Fever, lungs, pneumonia, cough, right? Because I have all this junk made up by the bacteria cooking and cropping and scraping every single little parenchyma inside my lungs and the alveoli. I'm not too happy about that. Check this out. Fever and flank pain. I might have pyelonephritis. Really? Yeah, because he just told you the fever gave it away. But this is flank pain, just gave it away. That's where the bacteria is. If I have fever and redness, erythema, pain, look at that, look under the skin, it's red, it's painful, cellulitis, staph strep. Oh, see? How about fever, right upper quadrant pain? Fever, right upper quadrant pain. I might have an ascending cholangitis. Can you see how it's giving it away? They literally give it away. Absolutely genius. So, these patients at the beginning of systemic inflammatory response, they will have a temperature greater than 38 or less than 36. Now, the second thing is their heart rate is going to go up. They're going to be tachycardic. They're going to have heart rate greater than 90 beats per minute. You need to memorize this. Tachypnea. Why is the patient tachypnic and their respiratory rate is greater than 20 beats per minute? So check this out. If the patient is developing systemic inflammatory response syndrome and they start to develop hypotension, slowly what happens is they develop metabolic acidosis. Metabolic acidosis compensation requires you to do what? Blow out the CO2 through your lungs. Look at that. So because you have all these acids built up in your body, because what? You're undergoing metabolic acidosis, because you're what? Going to sepsis, because there's a bacteria is about to cause a problem. You have to be tachypnic. Guess what? That explains why your PaCO2 is less than 32, right? Because that's the only way you can get rid of the CO2. Normal CO2 is 40. When you hyperventilate, you're going to blow up most of the CO2, and it's going to be low. Get it? Good. White count. Now the white count can either be 12,000, which makes sense, right? Because you have a lot of what? Neutrophils and monocytes, macrophages running to the spots. They're about to go kill the bacteria. So a lot of them are going to what? Flow inside your bloodstream. They're going to go find the source of the infection. However, you might also have less than 4,000 if you're immunocompromised, right? So if you're immunocompromised, have HIV, or you're on chemotherapy drugs, your white count might be really low. You might be leukopenic. So you might develop a leukocytosis, or you could be leukopenic. See, greater than 10% bands, that's a left shift. Usually the neutrophils are being rushed out and pushed out. And so you're going to see bandemia. Literally, immature neutrophils try to get out, try to buy their own guns to go start shooting and killing the bacteria. So, what is the definition of SIRS again? Before we lose track, you need two of this. So if the patient has just a fever, greater than 38, and the heart is up, that is systemic inflammatory response syndrome. Got it? 2. So you got to memorize this. Please memorize this. They will ask you one day in the hospital, you will be pimped. I guarantee you that. This is super high yield. Well, so when does the patient become septic? Well, when the patient becomes septic, they develop sepsis, not septic, sepsis, when they meet 2 of this and we know where the infection is. Remember my story? Here's the sepsis man, fever, headache. So if the patient has meningitis and they have temperature of 38 and the heart rate is 90, or temperature of 38 and the white count is high, guess what? Now they have sepsis. Get it? Get it? 2 of the systemic inflammatory response, plus we found the infections. We're like, look at you, we found you. You got a pneumonia. You're coughing up a lot of yellow, brown stuff out of your lungs. Lo and behold, pneumonia plus 1 or 2 of this, sepsis. Got it? So now let's break down the pathophysiology of sepsis. When the bacteria sneaks into the blood, the antigens on the bomb that this guy's wrapped around, right? Gram-positive bacteria, they have what? They have a thick cell wall made out of what? Peptidoglycan. The gram-negatives, they have lipopolysaccharides, and also the gram-positive have lipoteichoic acid. So the bacteria has different endotoxin surrounding the bacteria. So this is the way I think of sepsis in English. So the bacteria's got a lot of junk. Yeah, call it whatever you want, peptidoglycan, who cares? But these are toxins because the body doesn't want it. These toxins are gonna damage the endothelial cell walls, right? The endothelial walls inside the blood vessels are gonna be damaged. This is gonna eventually activate the presence of this endotoxin is going to activate your neutrophils, and it's also going to activate your macrophages. Cytokines, interleukins, they're all going to be flushed into the system. This effect overall will lead to systemic vasodilatation. That's all you really need to know. So all you need to think of from right now, these guys are going to start shooting and killing the bacteria. The content of the bacteria is going to leak out. The neutrophils and the macrophages are going to basically eat up the bacteria. In the process, it's a nasty war, and the war is not going to cause systemic vasodilatation from cytokines and your interleukins and all this chemical cascade. But the end result is you now get systemic vasodilatation. So all your blood vessels inside your body, they're going to be huge and big. That is called systemic vasodilatation. When your blood vessels open up and they're not vasoconstricting and they're vasodilating, you develop hypotension. What happens to your blood pressure? It's going to flush down the drain and it's going to be really, really low. Does that make sense? Because now all the blood vessels are basically open and they're like, whatever, right? Nitric oxide is going to contribute to that, causing systemic vasodilatation. Then if I have systemic vasodilatation, what's going to happen to my tissues? They're not going to be perfused. Now they can't get their nutrient. They can't get oxygen. They can't get glucose. And what's going to happen? You're going to develop lactic acidosis from anaerobic respiration, right? Because the tissues can't get perfusion, because hypertension will lead to what? Hypoperfusion, which will lead to organ failure. But also you will develop coagulopathy. So the way I think of it, the coagulopathy, the toxins are damaging the walls of the endothelial cells. When you damage the endothelial cells, what's going to happen? Von Willebrand factor, platelet is going to bind, platelet aggregation. This platelet aggregation are going to form microthrombi, right? You're going to use up your platelets, you're going to use up all the coagulation cascade, and all of a sudden you can develop DIC too. So that is serious. That's coagulopathy. That's one of the complications of sepsis. That was just how I remember it. It's pretty easy. So damaging the endothelial wall, just again, endothelial wall damage. Eventually you're going to have von Willebrand, and von Willebrand with platelet with fibrin. They're going to block the blood vessel, and now we can't get any perfusion. And what happens to the organ? The organ is going to get damaged. And that's it. But this is sepsis. That is the pathophysiology. Key. Hypotension, systemic vasodilatation. Hypotension, systemic vasodilatation. Now, let's come back to our sepsis pathway. We were right here, right? We said SIRS plus infection source. We know where the infection, if it's in the lungs, we know where it is. It's sepsis. Now, to develop severe sepsis, let's see what's going to happen. You have to have at least one organ failure. One organ failure. Well, let's find out which organ. Let's see here, right? So I'm not going to erase the sepsis, man. Let's talk about severe sepsis. By the way, just before we move on, before I forget, there are different kind of bacteria that can actually cause sepsis. We keep saying E. coli, but there's all his other friends. aside from E. coli, because E. coli causes a lot of pneumonia, right? Pyelonephritis, staph aureus, strep, right? Causing cellulitis. We also have Klebsiella, Pseudomonas can cause, so you can get Pseudomonas pneumonia that can give you also to develop sepsis. Another bacteria that we probably don't, strep pneumonia we already talked about. So these are all his friends that can cause you to develop sepsis. Okay, so don't forget, these are the bacteria, so that we make sure for completion's sake, those are the bacteria that causes you to develop sepsis. Now let's talk about severe sepsis. In severe sepsis, we said you need one organ, just one organ to be failing. Now let's talk about what are we going to see. Well, when you develop hypoperfusion and you develop lactic acidosis, let's check your lactate level. Lactate, it's usually going to be greater than 4 millimoles per deciliter. That is key. Lactate will be coming from your tissues because they're hypoperfused and they're converting pyruvate, right? You take glucose and convert it into pyruvate, which is now converted into what? Lactate. This lactate is the lactic acid that's produced. Lactic acid, and from the formula pH equals to bicarb, right? That's the formula we use to calculate acid-base disturbances. Lactic acid is going to be a lot of what? Hydrogen ions, which is going to decrease your bicarb because they try to buffer all this acid produced by your tissues. That in return will decrease the pH of the blood, make you develop lactic acidosis. So you always want to check the patient's lactate. That is telling your tissues is being affected. Well, also oliguria. Let's talk about that. Oliguria, right? And what do we mean by oliguria? Decreased urine output. Usually it's less than 0.5 milliliters per hour, per kilograms per hour. That means you have so much systemic vasodilatation, right? So this is your aorta coming from your heart, and this is your kidneys. Everything is so big, the kidneys is not getting enough perfusion because systemic vasodilatation is the key in severe in sepsis, right? So you develop oliguria and the kidney can't really filter stuff out and you're not peeing up, you have enough urine. What about you're going to develop an abrupt change in mental status? Change in mental status. Change in mental status, right? You're going to be confused, you're going to be lethargic, you're not going to know what you're doing. Why? Because the systemic vasodilatation is decreasing perfusion to your brain. So these patients also might develop, they might have mottled skin or delayed capillary refill. Mottled skin or delayed cap refill. Let's explain that. It's all from systemic vasodilatation, right? So if I try to check your capillary refill, it should be nice and red. When I press, it should be white. When I let it go, it should fill back within 2 seconds and be pinked up again. The problem is because they have so much vasodilatation, when you check for a cap refill, you're not going to get it back. It's going to be delayed. It's going to take longer. The patient also might be thrombocytopenic. Thrombocytopenic. Less than 100,000. Usually platelet count is between 150 to 400,000. This patient, if their platelet count is going down, that's explaining coagulopathy. coagulopathy, because they're using up all their platelets, because you're damaging the endothelial wall, causing the platelets to stick to the von Willebrand's. The fibrin is being made from the coagulation cascade, and eventually the platelet count is going to drop. This is systemic, the entire body. This patient can also develop acute lung injury, which is ARDS, or acute lung injury. That's another complication, because if the lungs is affected, that's one organ, right? If the brain is affected, that's altered mental status. The kidney is affected. So what did we say the definition of severe sepsis? Wait a minute. They have sepsis with one organ failure will give us severe sepsis. If they meet any of this patient is in severe sepsis. Well, we're not done. The story continues. Severe sepsis is now going to eventually go into septic shock. Well, we're going to go over and start talking about what septic shock entails. Hey, thank you so much for watching the video. I hope you learned a lot. Are you studying for the USMLE Step 1 or Step 2? Are you studying for the NCLEX, or you're currently in nursing school as a nursing student? Are you a PA student currently in school or studying for your PANCE exam? Or are you a nurse practitioner student or trying to take your NP board exam? Listen, I've got super awesome content for you. If you truly love this video and it simplified your learning process, I want you to check out my website below. I've listed all the list of exams, whether you're studying for any of this board exam, and all I want you to do is click on the link right now below so that you can take you directly to my website. For USMLE, just go to smashusmle.com. For NCLEX, go to crushnclex.com. And if you're studying for the PANCE exam, the nurse practitioner exam, or you're studying for your internal medicine board exam, just click below and it'll take you directly to ftplectures.com. Listen, I can't wait to help you. If you need to get in touch with me, just get to my website, you're able to reach me directly, and we can work together one-on-one. Listen, you're super awesome, and my goal here is to help your dream come true. If you want to be a doctor, want to be a nurse practitioner, a registered nurse, or physician assistant, I'm here to help you get to that next level. With your medical knowledge, let's save the world together. I love you guys. You guys are super awesome, and do not forget to click on the link below to be able to get to my website. Also, don't forget to subscribe to my channel. You guys have a great day. Let's go.